What I've been asked to talk about today is our national approach to case mix, or to understanding complexity in palliative care, and also our national funding model. But I will make the same comment that you can't do funding well if you're not thinking about outcomes, and unless you integrate outcome data collection and case mix data collection, you get it wrong. Because when you ask clinicians to collect data for funding purposes, they've got all the reason to fake it. When you ask them to collect it to improve the care of patients, they've got every reason to get it right. So that's my sort of opening line, and I will finish with that as well. I do want to give you a little brief introduction. One of the things I think that strikes me about Australia and England is that our approach to palliative care is very similar, and that's why I think a lot of the work goes together. There is one very big difference, and this is this one, that we have issues of size. We have 24 million people in a country that's more than twice as big as Europe. And so whilst our models of care in Sydney and Melbourne and Brisbane and our major capital cities look like England, the models of care we have in the rest of the country are completely different, and some of the issues for us, particularly in the remote areas where I have lots of interests. So if you're an Aboriginal person, you have to die on country, and you have to do your finishing up business on country, so there's this mad dash to get people 5,000 kilometres across the country before they die and all that sort of stuff. But the majority of what we do is very similar. So if I'm going to talk about funding, I do need to talk and give you a little bit of background about the Australian healthcare system, particularly because it's been so influenced by the British. So our starting point, just a little bit of history. The Brits established a penal colony in New South Wales in 1788, and then progressively the other states were established, and all of them were penal colonies except South Australia. They're very proud of that. And we didn't become a country until 1901. And in 1901, when we became a country, we formed a federal government, which we call our Commonwealth, and our 6 states were previously the British colonies, and the 2 territories came afterwards. And in our constitution in 1901, healthcare was deemed to be the responsibility of the states and territories, and the Commonwealth had no role in it. And that's really still important because that is still the case under our constitution, and our constitution requires 2/3 of the states, that is 4 states, and 2/3 of the population for any constitutional change. So healthcare is going to stay a state responsibility for a very long time. And in 1946, the Commonwealth got a very limited role, providing healthcare to returning veterans, and the British Medical Association, having lost the good fight for the NHS, got a clause put in so as not to authorise any form of civil conscription, which means we can't have a salaried medical service without providing an option of fee-for-service, because it's deemed against the Constitution, because it's deemed to be the conscription of doctors. And that's really important, that the Commonwealth in fact didn't get a role in healthcare until 1972, when we tried for what was then Medibank and is now Medicare. And in that 115 years, the states and territories owned and still own all the capital infrastructure of the health system. So the Commonwealth agreed in 1972, when it set up Medicare, that it would contribute 50% funding, and that was wrapped up in 5-year healthcare agreements, a very stable arrangement from 1972, and that ended on the 30th of June 13. So 30 years or so of doing that, and it all came to an end, and we no longer have 5-year healthcare agreements. And in 2011, when I was here, I was talking about what we thought was going to be the National Health Reform Agreement, which was then signed in the July, and I think I was here in the April. So the elements of that reform that remain important: hospitals remain a state responsibility. The Commonwealth contribution moved away from 5-year agreement to funding on the basis of what we call activity-based funding, but which people will also call case mix funding, payment by results. There's all sorts of various tariffs and currencies and all that sort of stuff. We got 2 new bodies, which we fondly call the IPA and the NIPA, the Independent Hospital Pricing Authority. Its job is to agree on tariffs and currencies and prices and all that sort of stuff. And we also got a National Health Performance Authority as well for public reporting. The Commonwealth role from 2012 under that agreement was that they would pay what is called a nationally efficient price for every public hospital activity, not just patient care but also teaching and research. They would fund at historic levels until this year, and from this year contribute 50% of the cost for new activity, and 45% from this year, going to 50% from 2017. They would also fund contributions for teaching, training and research, And there were very detailed arrangements for defining what a hospital was, which were basically pretty sensible. A hospital activity is something that happens in a hospital or as an alternative to a hospital or to prevent a hospitalisation. So all of community-based palliative care was considered a hospital for the purpose of the agreement, which we were really happy about. We'd been very concerned that they were going to limit what they were doing to that which happened in the grounds. So in terms of activity-based funding, Australian style, also known as case mix-based funding or payment by results, the IPA's role has been to define the activity units that it will fund, and it sets the price, and those activity units are called National Weighted Activity Units, NWALs. And we have clinicians all over the country now talking about NWALs as though it's something really familiar. And IPA determines the price that the Commonwealth pays to the states. It does not actually determine how much money goes to an individual palliative care service. States and territories are using the IPA model, but setting their own price. So in New South Wales, where I live, the state of New South Wales pays $350, a cost weight less than the Commonwealth is paying this year. But Western Australia, which has got huge travel distances, they're actually paying about $600 more. And I think that's been a really important feature that we've had to make clear to palliative care services. IPA is not actually pricing each patient you see, it's building up a budget for the state, for the Commonwealth contribution, and the state tops it up in the way it wants to. The nationally efficient price, there are 5 different classifications for different streams of activity. That is 5 different case mix activities. Acute admitted, subacute, including palliative care. So in Australia, the word subacute means function-related care. Acute care is diagnosis-related, and you'll get paid by a diagnosis-related classification. And subacute is function-related, and you'll be paid by way of a function-related classification. Outpatients, emergency department and mental health. And the overlapping area, of course, being outpatient subacute. And for the purposes of our national funding model now, we have agreed that if it's single discipline, if you only see a consultant or an allied health or a nurse in an outpatient clinic or at home, then it's outpatient. And if it's for it to be subacute, it actually has to be multidisciplinary team care. And that's made it, I think, fairly easy. And the units of activity are different for the two. We have one national efficient price across all of those activity, so that the national weighted activity unit is basically just cost weights that have been calibrated across. So everything from an ED attendance to intensive care or heart transplant have all got actually just one set of currencies. We have adopted a set of different national classifications. ARDRG, the Australian Refined Diagnosis Related Group Classification, very similar to HRGs, all based on the American model. I'm going to talk about the Australian National Subacute and Non-Acute Patient Classification, and I will present today the results I presented for the first time yesterday to the European group, and next Friday I'm presenting in Australia for the first time. So that's quite good. Outpatients by way of a clinic classification and so on. Here is version 2 and 3, because we didn't actually change between version 2 and 3, of the inpatient branch of the palliative care section of the classification. And you'll see the same phases that Fliss just presented, except that we call that last phase terminal. Remember, it's called dying here. We use a functional measure, which is the RUG-ADL, resource utilisation groups, activities of daily living scale, but it's doing exactly the same thing as any other functional measure, and it doesn't matter, we've mapped the two. We also collect the 𝐃𝐎𝐍𝐀, and you'll see that our deteriorating group is also split by age. We have a bereavement class, that is, the patient has died and the service is now providing bereavement support, and in the version we have just finished, we have actually deleted that class. And we are suggesting and we are recommending that it be dealt with as a payment issue, that if a patient dies, there is a payment loading, extra NWAL built into the payment model, so that to cover bereavement care. And that's a change in our thinking, that some things are better dealt with as payment loadings rather than in the classification. And so we're dealing with Indigenous status, remoteness, bereavement, and a number of other areas by loading up NWAL and pricing it higher rather than different classifications. And that's allowed us to reduce the size of the classification but add to the payment model. So the nationally efficient price is designed to be the cost of the efficient delivery, and these are the sorts of things that the legislation allows for: hospital type and size, hospital location, patient complexity, including Indigenous. We've just had our May budget a few months ago, and we all sat up on budget night and everybody just about fell off their chairs when the Treasurer announced, and nobody in the whole of the health system had any inkling, that the Commonwealth was moving away from activity-based funding and breaking the whole of the National Health Reform Agreement, that they would be abolishing the IPA and the NIPA, and they'd only just been established, and probably introducing a National Productivity and Performance Authority. And I thought I needed to tell you that so that you would think it's not only the NHS that goes through constant reorganisations, we do it too. In fact, for us, this is a really big change, because don't forget, we had 5-year healthcare agreements since 1972. So to move to this new model in 2011, when we'd had the same system since 1972, and to ditch it after 3 years has had everybody totally shocked. So the headlines for the budget is that the government announced that it's producing a white paper on the future of our federation, stressing that hospitals and schools will remain a state, not a federal responsibility. They have walked away from the National Health Reform Agreement after 2017, so that the 45% growth is still on for the next 3 years, but at the end of 17 they're going to revert to funding, putting their contribution to healthcare based on consumer price index only, population growth factors, which will reduce the Commonwealth funding contribution by from around 9% per annum estimated, taking into, that's for 3 things: changes in technology, increases in the size of the population, the ageing of the population, down to 6.5%. It represents an $80 billion cut in the budgets to the states and territories, which in Australia is a lot of money, and probably 3,000 or 4,000 hospital beds will close at least. The states and territories all got together and said swear words about the money. And it's very interesting because we have Conservative national government, and all but 2 states are Conservative as well, and all the Conservative health ministers all came out and said what an appalling piece of public policy it was. And they were on the same side. Imagine if they'd been on different sides. But one of the things the states and territories did was that they met and they agreed that all the work that had happened in ABF was going to continue, and they were committed to maintaining a national approach, recognising in their view that the Commonwealth will have to come back to the table at some time. So it's all business as usual. So ABF is staying, regardless of what happens at the Commonwealth level, and everyone across. And in fact, I think the level of cooperation in the last couple of months has actually been better, because they've all got a common enemy again. So this takes me now to SNAP and where that's up to. The IPA commissioned us this year to develop version 4 of the SNAP classification, and we'll show you some headlines about that. We did our first version, I can't believe it, in 1996 in a study we started planning in 1994. We did the pilot in New South Wales, and my colleague at the time, David Cromwell, was who did the statistical work, is now at the Royal College of Surgeons of England, and we were talking about it when we met the other day, because they're trying to work out how to measure variation in their surgical outcomes as well. So it feels like a long time ago since we did the 1996 version. And it is good to see in the last 2 or 3 years, I'm not sure, I don't understand how things happen in terms of implementation, how it takes 18 years or so, but it's getting there. We've had in Australia bedded down for a long time. We did other versions in 2007, 2012, and now the current one. Our original study was based on 30,000 patients in 104 services in Australia and New Zealand, where we managed to convince thousands and thousands of clinicians to walk around with clipboards and write down in minutes per day for every patient how much time they'd spent, and we costed every patient's day of care on a bottom-up costing for 6 months and collected all the clinical measures we're talking about. There are 124 classes in our latest classification, and the IPA and the states and territories have already agreed to a national implementation from the 1st of July next year. So the scope of the classification is care in which diagnosis is not the major cost driver, that is, it's not the major measure of complexity. When a patient is dying, it doesn't actually matter whether it's cancer of the lung or liver or MS or any other factor. What's driving the need for care is the stage of illness, signs, symptoms, the sorts of pain, the sorts of family complexity, the sorts of things you know about. So subacute care for us is care that's focused on the enhancement of quality of life and or function, and non-acute care, the other part of the SNAP classification, is maintenance and supportive care. The classification itself, just to put it into context, has 5 care types, palliative care being the first, and it is an algorithm. If a patient meets criteria for palliative care, go no further. If not, are they rehabilitation? Are they psychogeriatrics? Are they what we call GEM, geriatric evaluation and management? These are patients with complex multi-system problems without a clear principal diagnosis. They actually have geriatric syndrome, classically, and non-acute. We have what we call our episode types. Our overnight admitted is what would be called a hospice here. Same, we have a classification of same day admitted. It's a bit of a strange classification, but it's basically a patient who goes and sleeps in their own bed at night, but they've still undergone the hospital's formal admission process. Outpatient, they've come, we've seen them in an outpatient clinic or other setting, or community, we've seen them at home. What we call consultation liaison or in-reach, you would call hospital, and we classify that as ambulatory, and I'll explain that in a minute. In our original study, these were the factors that we picked up that were the cost drivers. The care type, that the rehab patients really were very different from the palliative care patients. We could test that, and we did. Function, both motor or physical function, but also cognitive function, is to this care what diagnosis is to acute care. And it's the most critical, and it's common to all of them. Phase for palliative care, for the rehabilitation patients, it's impairment. For psychogeriatrics, which is patients, frail older people who've also got concurrent mental health issues, including significant dementia, and age. And in palliative care and rehab, the younger you are, the more resource intensive you are. And in GEM and in non-acute, it's the reverse. We also picked up additional cost drivers in the ambulatory setting. Problem severity. Problem severity was not predictive of cost in the inpatient setting or in the hospice setting, but it was in the home setting. And also issues around carer, about both the availability of carer. The availability of carer did not influence the cost once you were in a setting. What it influenced was what setting you were in. If you didn't have a carer, you wouldn't be at home. But once you were in hospital, then we couldn't see that the carer availability was different. So here's version 4, hot off the press. There are 124 classes in the new classification, 20 for adult palliative care, and for the first time we now have paediatric palliative care with its own classes, only 8, and we have a very low volume of paediatric palliative care in Australia. We only have 6 specialist palliative care paediatric teams in the whole country, and most of what they do is consultation liaison or in-reach. We have 89 classes for overnight, of which the largest share is rehabilitation, and rehabilitation care is quite different between Australia and England. It's a very large specialty in Australia, much larger than palliative care, whereas here it's the reverse. Just in terms of some headlines, in terms of paediatrics, we've created 8 classes, 4 for inpatient, 4 for ambulatory. They're based on clinical consensus, not on data, because we didn't have enough. We have agreed to use the adult definitions of phases for now, but there's interest among our paediatric palliative care colleagues in moving to 3 phases into the future, and that's by amalgamating unstable and deteriorating and talking about patients being either stable, complex or terminal. I'm not exactly excited about the word complex, because who's going to say that anyone's got other than every patient will be complex, but I do think the idea is quite sensible. So here they are, the top 4, called FB are inpatient classes and the SO are outpatient classes. And you'll see that the classes are the same, and I'll start at the bottom, it's easier. All children who are in the terminal phase or dying phase go into class 4. If they're not terminal but they're less than 1, they go into class 3. And if they're over 1, then they're split into stable versus the other 2. And that's it. And then it's repeated in both settings. For inpatient, we've maintained our basic structure. We've deleted assessment only. We did this classification 18 years ago. There were a lot of patients admitted for assessment only 18 years ago. There just aren't anymore. They're either assessed in their own home or they're provided with a consultation liaison service, and we'll count it as that. We have split the unstable phase into patients who are admitted in the unstable phase. It's their first phase for this episode or this spell, versus those who become unstable whilst in care. We're not entirely excited by that. And in fact, on our benchmarking work, we've actually deleted that distinction. So it'll be interesting to see what your data looks like for the UK. We have maintained the RUG-ADL. We did a national consultation about moving away from it on the basis that it was a good instrument when we adopted it 18 years ago. But there are now better ones. There was really no appetite for change. People said, look, there's things that are actually a bit better, but it's actually working really well. Why disrupt it? And we're going to lose all of our historic trend data and all that sort of stuff if we move away. We've done some age splits in deteriorating, and we've abolished the bereavement class. On the ambulatory, we've got same-day admitted, outpatient, outreach and day program, and for the purpose of case mix funding, consultation liaison or in-reach is considered to be ambulatory. That you are seeing a patient in a ward is no different than seeing them in their own home or in an outpatient clinic. It's now only for multidisciplinary palliative care. As I said, if it's single discipline only, you go off to the outpatient classification. And we've got classes split on function, which is the RUG-ADL, on problem severity and on phase. For consultation liaison or in-reach care, this is where patients, and this is I think what you call hospital, patient is under medico legal responsibility of another stream. The IPA has been in general pretty good. This is one area where they've been hopeless, which is that they have not been prepared to recognise consultation liaison as a separate activity for ABF purposes. However, we have treated it as ambulatory care, and the states are pricing it separately and paying for it irrespective. So, and the IPA has had this view not just about palliative care but about mental health and rehabilitation and everybody else. I do want to make a couple of comments now about implementation. We have implemented in the same way that you've got OAK and you've got Sea Change. The centre that I direct is the Australian Health Services Research Institute, and we developed the SNAP classification and we run the National Case Mix and Classification Centre. And we did that work as part of that centre, but we also run the National Palliative Care Outcomes Collaboration, or 𝐃𝐘. And 𝐃𝐘 is a collaboration between 4 research groups across the country, which is my group in New South Wales in Wollongong, just south of Sydney, Patsy Yates's group in Brisbane, David Currow's group in Adelaide, and Claire's group in WA. And we've been working together as the Palliative Care Outcomes Collaboration for quite a long time, and in fact for 8 years. And one of the reasons it's been really easy to implement activity-based funding in subacute palliative care across the whole country is because everybody was already collecting these measures for outcome purposes. And that's a really important part of what happened in our country. We've got a national program that uses standardised clinical assessment tools to measure and benchmark patient outcomes in palliative care. It's a voluntary program. Services participate if they want to, they don't have to. We only have 5 non-participating services in Australia on a purely voluntary basis, which we're pretty pleased about. The data required for the SNAP classification are the same data required by 𝐃𝐘 since 2006. And more importantly, in 𝐃𝐘 we never use the word data. we talk about introducing standardised, valid clinical assessments. And we work with people to stop doing what they were doing, move to our clinical assessment tool so that it's no extra work, and to use those clinical assessments as the basis of their care planning. And because people are using that information to plan the care for their patients, the data quality are excellent. What we do for benchmarking and what the Commonwealth and the states do for funding is a byproduct of the fact that clinicians are happily collecting this data, not because it's data, but because it's basically clinical assessment. And we say to people, just like in acute care you take a blood pressure and you take a pulse, this is palliative care's equivalent of vital signs. And it's not a data collection. And I think because of that, we've got really good data quality. And we use the one data set for all of those purposes. Here are our quality and outcome measures. We do measure changes in phase. We do measure changes in function using both the RUG and the 𝐃𝐎𝐍𝐀. We do measure changes in problem severity. And I do want to make a point that for us, our outcomes are measured by phase. So we have a patient will come in unstable, collect measures. Patients are in the inpatient setting, have a phase assessment every day, and in a home setting every time they're seen, and a change of phase triggers a new clinical assessment. A lot of services choose to do it more often, but we only collect data for each phase change. So the others are what you'd expect: how episodes start and ended, average length of stay by phase, place of death by level of support. We do have a series of access measures around where people live, how far they travel, people who are Aboriginal and Torres Strait Islander, actually language, country of birth. And we have the same issues, that our services are predominantly provided to English-speaking Australians and a very small number of Aboriginal people. We do measure time between when the patient is ready for care and when they start their care, and we do measure time in the unstable phase. I'm just going to show you a couple of measures because we've been doing this for so long now. We set our baseline back in 2008, and we do know how to case mix adjust our outcome measures to adjust for changes in the profile of phases and symptoms, changes in symptom start scores in that time, because it has actually changed. And that case mix adjusted outcome measures is now just routine for us, and I'm really happy with the sort of work. We set our baseline back in 2008, and this is the percentage of patients who are doing better than the average in 2008. And so if you look at the top line, which is nausea, nearly 85% of patients are getting outcomes that are better than the average back in 2008. And we've just had a paper accepted for publication, which will appear in the next, hopefully soon, looking at 30 services that participated in 𝐃𝐘 over the whole period, where we were able to show statistically significant improvements in all of the measures I'm about to show you, except pain. We got improvement in pain, which is the dark blue one at the bottom, but it didn't reach quite the level of statistical significance that the others did. So the top line you'll see is nausea, the green line is breathing, the red line is bowels, the bottom one is pain. And we're really very pleased about this, and being able to show this to our health ministers and say, look, this is the outcomes we're achieving in palliative care across the country. It was pretty politically helpful too. We like doing that. These are our other measures, the top line being psychological, spiritual problems, the green being all other physical symptoms, and the bottom one being family carer issues. We are happy to say that we're comfortable now that these improvements are due to better clinical assessments leading to better care planning. And a lot of our services have been able to demonstrate that in quite nice ways. We also, one of the other centres we run is AROC, the Australasian Rehabilitation Outcome Centre, where we've got an application in at the moment for some money for a randomised cluster trial to have a QIF in half of our services and no QIF in the other half, and see if we can actually measure the impact of having a QIF, a quality improvement facilitator. I do want to just move on to some bigger design issues, but I really did want to show you that outcome measures, because I think and when we're talking now about thousands and thousands of episodes, where certainly more than 90% of all patients receiving specialist palliative care are now being assessed using the measures we're talking about and are appearing in our national data set. And we were able to use that data set for our case mix classification work for version 4 of the SNAP classification. I do think it's important to distinguish between the idea of a classification and a funding model and a price. And the question that Fliss was asking today is a really important one. What classification variables are required to explain differences between patients? And then for me now, what variables are better dealt with as a price loading rather than as a classification variable? And so for us, it is bereavement phase we think is going to be better dealt with that way. Patients who are Indigenous, patients who don't speak English, remoteness, a whole range of other factors, whatever those factors might be, where you can actually load them up. And the way that that works for us, as I said, is that we've got a cost weight or an NWAU, a National Weighted Activity Unit, and any of those factors just adds points to your NWAU. And then the other question now is, are there other sorts of factors that best explain cost differences between providers and how to use that information in pricing? And for us, that is certainly a remoteness factor. Our cost of providing healthcare in our remote areas is incredibly expensive, irrespective of whether they've got any patients. Total, for those who know the costs of running hospitals, Royal Darwin Hospital, 30% of the cost is on air conditioning and clean water and electricity. Huge differences. I do also want to point out this slide, and this is a piece of work we've been doing over many years about the idea of bundling care. So at the top there's a person, and in the course of their life they have multiple episodes of illness, and one of those ends up being one that's going to lead them into having an episode of palliative care, so an episode of care or a spell of care. And we've now added a level below that within a spell of care you can have one or more phases of care, and within a phase you can have one or more days of care, and within a day you can have one or more events. And the funding principle's really clear. The higher you bundle, the more the provider carries the financial risk. And the lower you bundle, the more the purchaser carries the financial risk. So at the European group that I met with the day before, I actually said, here you go, I'm referring you a patient who's got metastatic melanoma, and you're the oncologist, and I'd like you to accept one payment for all of their care, for the whole episode of illness. And nobody in the room took me up on the offer, because they all understood that they couldn't predict what was going to happen, and therefore it was risky. And when I said, okay, well, let's unpack that same patient, I'll pay you a fee for service for every time you see them or every time you do something, and everybody ran at the opportunity. So the principle for funding says you want to bundle up as high as you can to the point at which the care is still predictable. And for us, that's the phase. We're able to predict quite well the model of the type of care you need for a phase. And so our funding model for Australia now is that we're paying by phase, but we also have an element of per diem, because we're wanting to neutralise, per day, we're wanting to neutralise the incentive to treat in any setting. We want the setting to be the financial model, not to create an incentive to admit or discharge, and not to create an incentive to have patients at home or in the community. I do want to make an obvious point that a classification is not a funding model. First you develop a classification, then you design a funding model that's got the right incentives, how high to bundle. And for us it is per phase, per day. What incentives do we want to create? We don't want to create incentives to send patients home quicker and sicker, as they do in acute care. We do want to create much more neutral about setting of care, and have setting determined by patient preference rather than financial incentive. And then we also really do need to pick up this issue about what's possible now and what's possible later, and what's the development path to get there. And we may have to start with something that's less than ideal, as long as we've got a work program to get there. And the thing we keep saying to everybody in Australia is improvement comes by doing, perfection comes later. And we think we're still in the doing stage, but we're a long way from the perfection stage. Very quickly, our payment model is called the blended payment model. We do pay per phase, and that varies by the class. We also do pay a per day rate, which is the same across all classes. That basically covers your hotel cost of being in care. And we do have special rules for outliers, and they're then converted to a total NWAL for each payment. And just in terms of what we know about costing and pricing in Australia, a palliative care bed day costs about the same as an acute medical day. And we have a national hospital cost study in Australia that's done every year across private and public hospitals, and palliative care is now costed by phase in that study as part of routine practice. There are some issues for us into the future. One's around new models of care. The second is about how to deal with linking quality and outcomes, and we're very comfortable with the idea that the way to do it is not to link it directly. So we're not happy about paying for performance type models, and we don't think there's any evidence that they actually work. We think the best evidence is doing things like 𝐃𝐘. We haven't had gaming as an issue in Australia in palliative care, but we certainly have in other parts of the system. In acute care, people writing down that the person's got a brain tumour when they've really got a headache in order to get a higher payment. We haven't had that in palliative care, and the reason we haven't is because people are using the data, they're using the clinical assessments for patient care, and they're using the measures for measuring their outcomes. My final comment is we have been doing a lot of this work. There is a lot of international interest now. We've had approaches, obviously we're working very closely with you, but also from the Canadians and Singapore and Hong Kong and a number of other countries that are interested. So we're very happy to collaborate and share our expertise and learn from your experiences as well. Thank you very much.